Welcome back. In your first lesson, you learned how asthma severity is classified in children 5 years old and older. Today, we will see how asthma is classified in those younger than 5 and why this can be a more challenging task than in your older patients. By the end of this lesson, learners should be able to identify components used to classify asthma severity in children 4 years old and younger, differentiate asthma severity based on clinical findings, recognize the role age plays in asthma severity classification, and understand the ambiguity of diagnoses that can accompany a wheezing child. As a reminder, this lesson is not all-encompassing. It is meant to give you the most high-yield information. For further information on asthma severity, visit the Resources tab on our website, where the EPR4 and GINA guidelines have been made available. So let's start out with a clinical scenario. Pause this video and read the clinical vignette below and think about how you would classify GINA's asthma severity before moving on. We will revisit it later on in this lesson. Asthma severity can be defined as the intrinsic intensity of the disease process. In other words, asthma severity is how bad a patient's asthma is, which helps us determine how to treat them. Severity is different from asthma control, which will be covered in another lesson. Within the domain of asthma severity, there are 4 categories: intermittent, mild persistent, moderate persistent, and severe persistent. The 2 domains of asthma severity are current impairment and future risk. Current impairment refers to the frequency and intensity of symptoms and the functional limitations the patient is currently or has recently experienced. In the table below, you can see the 6 components of impairment. For the purpose of this lesson, however, we will only focus on the first 3 components: symptoms, nighttime awakenings, and SABA use for symptom control. The second domain of asthma severity is future risk. While some patients may appear to have minimal day-to-day symptoms, they still may be at a significant risk for exacerbations. In this domain, the only component we will focus on are asthma exacerbations requiring oral systemic corticosteroids. Now, let's take a look at each one of these components individually and see how they influence asthma severity. The first 2 components we are going to talk about are symptom frequency and SABA use. Examples of asthma symptoms are how often the patient is having cough, wheezing, shortness of breath, chest pain, or difficulty keeping up with their friends. The most common SABA rescue inhaler you will see used is albuterol. Now, the first question to ask yourself is the patient having symptoms or needing their SABA more than twice a week? If they aren't, their asthma is considered intermittent. But if they are having symptoms or needing their SABA more than twice a week, their asthma is persistent. If your patient is having symptoms or SABA use more than twice a week, ask yourself, is it daily or is it multiple times a day? If their symptoms or SABA use is daily, their asthma would be classified as moderate persistent. But if it's multiple times a day, their asthma would be classified as severe persistent. So 2 days a week is the threshold for intermittent versus mild persistent asthma. Daily symptoms or SABA use is moderate persistent, and multiple times a day is severe persistent. The next component we're going to talk about is nighttime awakenings due to asthma symptoms. This component is extremely straightforward in determining whether a patient has intermittent versus persistent asthma, because if the patient is awakening at all overnight due to symptoms, their asthma is automatically some degree of persistent. Now, it's also clear that if your patient is waking up weekly with symptoms, their asthma is likely severe persistent, but anything between no symptoms and weekly symptoms can be difficult to distinguish. While there are clear-cut numbers that help distinguish mild persistent and moderate persistent asthma in the tables below, instead of splitting hairs between waking up 2 versus 3 times a month, I would use the information to help support whether their asthma is intermittent versus persistent, and then take other components of asthma classification into account. The last component we are going to discuss is asthma exacerbations requiring oral steroids. Now, regardless of age, this is extremely straightforward. If your patient has needed oral steroids more than once in the past 12 months to treat their asthma symptoms, their asthma can be classified as persistent. Everyone can use oral steroids once in a year before their asthma is considered to be persistent. Now, being able to distinguish mild, moderate, and severe persistent asthma cannot be easily classified based on oral steroid use. But, as a general rule, the more courses of systemic steroids needed for asthma symptoms, the more severe the asthma is. While the diagnosis and classification of asthma may seem straightforward based on components discussed, it can be challenging in infants and toddlers. This is because wheezing, while a classic symptom seen in asthma, is extremely nonspecific when it comes to toddler illnesses. In fact, 25 to 30% of all infants will have at least one wheezing episode, while half of all children will have a history of wheezing by 6 years of age. While some of those cases may truly be asthma, a surprisingly large number are not. In fact, One study found that while 1/3 of all children studied had at least one wheezing episode in the first 3 years of life, almost 2/3 of those same children saw resolution of their wheezing by 6 years of life. Below is a list of some of the most common non-asthma causes of wheezing. One way to help distinguish if your patient is wheezing due to asthma or another cause is determining if the wheezing responds to bronchodilators. If so, it doesn't completely rule out other factors, but it's more likely that their wheezing is due to asthma. This should prompt you to ask more questions. If it doesn't respond to bronchodilators, look for other causes. Back to our clinical scenario. Gina is having wheezing that does respond to bronchodilators. She's having daytime symptoms 1 to 2 days a week, but never any nighttime symptoms. She's only had one course of oral systemic steroids in the last year. So, based on this, we can classify her asthma severity as intermittent. When trying to determine a patient's asthma severity, it's important to look at the whole patient. Their story may be inconsistent when it comes to one component such as daily symptoms or nighttime awakenings, but if you see they are using their SABA frequently or they're having multiple oral systemic steroid courses, that information can help direct your next steps. Lastly, the asthma severity table is full of information and can get confusing. If you can't memorize it all, find a memory hook that works for you. I find the below memory hook about SABA use helpful. This month, this week, this day, and all day. If your patient is needing their SABA monthly, their asthma is likely intermittent. If they're needing it weekly, it's likely mild persistent. If they're needing it daily, it's likely moderate persistent. And if they are needing it all day or multiple times a day, it's likely severe persistent. And remember, not everything that wheezes is asthma. Now, head to the practice section on the asthma curriculum website to continue honing your asthma classification skills.